Our next patient is a 60-year-old male with permanent atrial fibrillation. The last cardioversion was in June 2012. After an ACD closure in January 2014, he started on clopidogrel in addition to aspirin and fenbromide. In November 2015, a subarachnoid bleeding occurred. His concomitant diseases are hypercholesterolemia, hypertension, and a dialysis-dependent terminal renal insufficiency, unsuccessful kidney and pancreas transplantation in 1969 and 1999. He also suffers from renal anemia and right-sided nephrectomy due to renal carcinoma. His risk scores are a CHATS score of 2, a CHATS-VASc score of 2, Hasbled score of 4. His ECG showed atrial fibrillation, a right bundle branch block and left anterior fascicular block, and TTE showed a dilated left atrium of 45 millimeters and a mitral valve regurgitation, a mild mitral valve regurgitation.
Okay, thank you very much. So the issue here is obviously the prior ASD closure with the device. We were not able to get a detailed report about the procedure, nor the echo recording or TE recording, so we don't know yet. There may be an additional problem, and that is, Busha, can you show us what you have seen on echo regarding the left atrial appendage?
Yep. So this is one of the views. I'll show you another one. Any comments from the audience?
I think it looks big and lots of spontaneous echo contrast.
It looks as there's sludge at the distal bit of the distal tip of the appendage.
Mm-hmm. Yeah, this thing here.
Is it sludge or is it a thrombus? The answer is yes, right?
Yeah.
Try the Levervist trick.
Okay, so should we do this live or should we just show you some pictures we've done?
Let's go through the pictures first.
Okay.
Then let's vote.
Okay, so just further up. So I'll show you a few pictures. That's the first one. So contrast is coming in. So you can see the contrast is, and obviously there's a lot of low flow. The velocities are less than 20 centimeters per second, which is typical for very slow flow and increased risk of thrombus formation. And you can see right at the tip, there's a lot of echo contrast hang up. And in the long axis, you can see this black area. Yep. So you've got this, it looks like, potentially, a filling defect. So we gave some more contrast, because we know that sometimes we have to give quite a bit and give it time to fill. But as we did, this is what we saw. So just at the tip, we've got definitely there an area that just doesn't fill with contrast. And that coincides with that echogenic mass loose mass we were seeing. So what are people's thoughts on that?
Comments?
Looking really
I think it looks more like a pectinate muscle than anything else. Yeah.
Well, we thought
muscle should be bright though, right? This is a dark. Appears to be a filling defect.
Do the Levervist.
Sorry?
Do the Levervist.
Well, we did.
We did. That was it.
That's it.
That was it.
This is it. This is the echo contrast you're seeing here.
Would it help if you put some ordinary contrast, an X-ray contrast, because it will stain if it's clot anyway, no?
Well, we didn't do the transeptal puncture yet.
Oh, I see.
Yeah, I think it's part of the structure. It's not sessile, it's not moving.
Well, I mean, there's this echo dense thing, which is trabecular, but there's also a more flimsy thing, which is either sludge or thrombus, as we discussed.
What is the flow velocity?
This one. This one here.
This is not your typical trabeculation. So this is a cauliflower-type appendage, and you do wonder whether you might be looking at trabeculations, but it doesn't follow that line. It's not well demarcated. It's not echo bright like the rest of the trabeculations are, and it's an unusual shape. And associated with that was a lot of contrast as well.
Bushra, if it wasn't a LA appendage closure workshop or course, you would have said that was thrombus.
I would have said that was thrombus, particularly having given the echo contrast, and it's a clear filling defect.
Well,
it just never fills.
Morris may feel differently, but Shaq and I definitely say don't proceed.
But Jackie is the one who published about doing it.
Not for clot, no. I have done it.
Yes,
in a setting.
Or maybe verbal communication.
I think in a setting where the patient has been anticoagulated and has a residual layered thrombus, we have done that, trying not to go deep and really doing minimal contrast. I mean, you got to consider a whole patient as a whole, right? And this patient has had a subarachnoid bleeding. Obviously, there's a lot of contraindications for anticoagulation up front. But I think the other aspect was I like to see that ASD. I like to see the interarterial septum. And if you add everything together, the risk is too high. Then
So the patient had subarachnoid when?
That was 2015, November 2015.
So anticoagulation to make this goes away has its own risk.
absolutely.
So the question is, which is the risk greater, of a brain hemorrhage or you throwing a clot? And that's what it boils down to, if it was a clot.
Kevin, question here, and then DJ.
May I ask the questions about anticoagulation in this patient? Is the anticoagulation interrupted? And if it's not, or it is, what type of anticoagulation?
I think we don't have these on the slides. Maybe, I think she doesn't have any, he doesn't have any at this time, but we will check.
The reason I ask is that if the patient is anticoagulated appropriately and it's not interrupted, the question is that if you don't do something about it, yes, what is that thrombus going to behave, and how are you able to prevent stroke with anticoagulation? As an electrophysiologist, when we do AF ablation, we routinely do TOE, and we see a number of patients with this kind of appearance, with a clot in the left atrial appendage, even they are fully anticoagulated. In some cases, also added antiplatelet therapy. So what we did is, what I did, is that when we see the semi-formed clot, or in your case, more than semi-formed clot, we administered heparin and get the ACT up and repeat the TOE pictures. And sometimes we see resolution of this and allowed us to proceed with the procedure.
After what time?
20 minutes and 30 minutes. Yeah.
Oh, 30 minutes, okay.
So we usually do TEEs at the time of implant. We never, ever, or rarely took the patient off the table in the past because we saw clot, rarely, 1%, 1.5%. But now with NOACs, since everybody has moved to NOACs or DOACs, we have now taken in the last 100 patients, 6 off the table. So what I would do if that was the case, as you were saying, is I would make sure I would put it under controlled warfarin and measuring the INR at home, because there is now a way to measure it on every second, third day basis, and try to do tight control using warfarin.
Well, the other option is, this is really not very mobile. It's too distal in the appendage. So we can use what YYLAM did with some of his cases. Actually use a device where you don't have to have a deep engagement of the appendage and still be able to deploy and close it, because this patient seems to be relatively tricky, and putting him back on oral anticoagulation may not be a great option, and we may be in the same situation again coming, even if we cancel the case today.
Martin.
What is an option is if from the TAVI field you have Claret or another protection device. We've done that in patients that came back after 4 weeks of complete or anticoagulation and still had a clot. And obviously, it's not enough cases to have any conclusion, but I think with the safety data of the Claret that were just published at TCT, it's a good option.
Stefan.
Sometimes it doesn't make a difference, but Bushra, I'm just wondering how much echo contrast you administered. Sometimes if you increase the dose of, say, Definity or whichever agent you're using, you might improve the visualization of that apex.
Busha,
Yes.
what do you think?
Yeah, so ideally, when you're giving echo contrast, you need to keep it agitated. And this kind of study is difficult when it's low flow. And the ideal is to really have a pump where you have a continuous infusion going through for several minutes. And that's where you really make sure you've got good opacification and the contrast has had an opportunity to go everywhere, but without then dispelling and losing the bubbles that you want to create, which is how you then see the filling.
So, Horst, what are you going to do now?
So, Busha, you said with a higher dose on the pump, infusion pump?
Yeah, that's ideal when you're looking at
So
this kind of
why
thing.
not to do that?
I think you wouldn't lose
Do we
anything
have-
just by
do we
doubling the
have some
dose and
echo?
taking a look.
Just give a higher dose.
Yeah, we can do
Or we
that.
can use a pump if you want.
Well, you keep agitating and just keep injecting small amounts, then we'll keep the flow going. We
Okay,
can
so
do it
go
that
back
way.
to lecture because we need some time to prepare the echo, and we show you the pictures thereafter.
Okay, thanks, Horst.
Horst, you're live again.
Did another echo study with more of this echo thing, echo contrast. So let's look at that.
So I think, Stefan, you made a really good point about when you're giving contrast to make sure you've got enough contrast in the cavity you're looking at and that it's not being washed out quickly in order to look at this. So this is us giving higher doses in boluses and giving big flushes. So I think we've got good opacification of the appendage here, but you can see this filling defect here. Now, if I go to the next picture on X-plane, you can see something here and something here. Now, Horst made a really important point, saying that actually when you're looking at this, it's changing. So are we sure this is definite solid thrombus? And my view looking at these and doing this for a while is that I suspect it looks like it's changing because the flow is changing here. I think just at the tip there probably is a little bit of solid thrombus there, but it is right at the tip, hidden in the tuberculations. That's my feeling. I think there is something there, but I don't think it's a big thing.
It sounds like maybe the best of both worlds is the minimal no-touch technique. It's a big appendage that's we've heard for the last 2 days how you could do it with advancing the ball and staying where you want in the landing zone and in the body. That's what I would vote for.
I agree with Maurice. We had a little brief discussion there. I think if you take the overall picture for this patient, I think if doing this procedure with meticulous technique, perhaps just echo guidance almost completely, probably is in the best cost-benefit, risk-benefit ratio is best in the patient's favor.
What we will do now is do a transeptal puncture, if we can, and then give some contrast, echo contrast into the left atrium.
Yep.
So let's look for the long axis view of the septum, please.
So Horst, how are you going to plan your transeptal puncture? Because that device looks pretty big.
Yeah, look at the long axis view. Here it is.
Nicht bewegen, nicht bewegen.
And I think I saw a lot
Fortunately,
of
the
contrast
inferior
there.
part is spared.
There's a very small inferior.
Yeah, the inferior part is spared.
So I think we can do it there.
I'm just going to eye scan that again because it's just
So that's
too
what I'm
difficult.
aiming for. I'm coming down.
Explain.
Can you zoom in? It's hanging on the device. Jetzt mal nicht bewegen da oben, ja. Ups. Okay. So now I'm, according to fluoro, I'm at the inferior edge of the device. Don't know whether you can see me.
Yep.
Horst, would you think about using RF here, given it's a little bit thicker down, farther inferiorly? Would that
Well,
help you?
we usually don't use RF, but it's certainly an option, no question.
Yeah, depending on whether this, it depends how your needle goes through this here. But I think that I would like to see better tenting.
Yeah, tenting at all.
So
huh?
this is a case where ice, I think, is very, very helpful.
What?
Intracardiac echo.
What ice?
What?
We're back again.
In this case, I think it's very, very helpful.
Well, you have the device as a guide.
Yes.
Basically, you just have to touch the edge of it and go through.
I think in a couple of views, again, if you not the X-plane, but the regular short axis by
go to
itself
the-
to
yeah,
give you the freedom, you'll be able to see it.
And try to go to, in a short axis, go to the inferior edge of the device.
The short axis, not X-plane.
Go deeper.
The case does illustrate that that closing the
pushing.
appendage in a patient who's had some AFib before you close the ASD is sort of a good strategy.
Absolutely.
That's good.
Yeah, and the ASD closure was performed just 2 years ago, so it's a pity. Yeah?
I brought a case to illustrate this exact same point, where the ASD, so we had to do, before closing it, plan where the puncture is close to the, and not go through it, so we have a coverage of both at the same time as we go back out.
I see on fluoro that I'm touching the device, or just the septum below the... let me go to the another plane on fluoro. Achtung.
Bushra, can you do 3D on this to see where the catheter is?
We can try, yeah.
So now in fluoro it looks I'm really at the inferior edge, that should be fine.
Yeah.
Let's go back again. If possible, I want to see the tenting because then I avoid going through the mesh of the device.
Yeah, if you shoot the tenting away from it, then you're set.
Herr Gruber. Yeah.
Just come up a bit, come up a bit. That's it. Well, shall we
So
stay
I'm
like
really
this, or
touching the
can
device.
we use 3D?
Let me do this again and give a little more bend to the needle.
Did we see tenting there just for a second?
No, I have retrieved the needle. So currently, if there's any tenting, that's not caused by me.
And I saw on the slides, usually you do a BRK or BRK1?
BRK1.
One.
Maurice, have you had experience in the past puncturing through the device itself?
And I try very hard not to go through the device. Because maybe I'm sure that sometimes we're there.
Yeah, we can, but it's much more cumbersome to do this.
Especially when the 14 French sheath, everything starts to show tilting, the whole septum starts to tilt, and kind of like...
You have to predilate,
It looks very bad. So everybody in the cath lab says, stop.
Horst.
Yeah.
When you're doing this kind of transeptal puncture very close to a device, is there any minimum clearance or is there any minimum interval from implant that you would wait before doing this?
No. I just want to stay away from the device and away from the pericardial space, which is the concern in this area here.
Yep. Yeah, I think showing the tenting is imperative, in my opinion.
Yeah.
So, Horst, we can see you scraping down the side of the device very posteriorly, inferiorly. You're somewhere here. I can see you moving.
So, do you see any tenting now?
On the inferior part.
Yeah.
He is more inferior.
Can't see any obvious tenting.
Are you looking inferior enough? I'm sorry.
Yeah, we're...
Oh, this is more short axis, huh?
Yeah.
It's, or intermediate axis, huh?
So let's go to 50. It's 90.
It's not real short.
Well, you can go either short axis way below the device or long axis is also.
So we're in long axis at the moment.
Yeah, if you go to short axis.
And the short axis is on the right screen there. And we're just looking at the inferior portion there. So you can see the IVC, can't you, coming from there as we move up. We're already not seeing anything on that septum.
I'm pushing a little harder now.
Okay. Oh, is that something there?
Is that tenting?
Are you just yes? You've just gone through.
Yeah, you're displacing the tissue.
Yeah.
It's not the standard tenting, but it's displacing.
There, we can see you tenting there, Horst.
Yeah.
You're right at the...
That's right. And on the floor, you're just underneath the device.
Yeah, you're good.
Yeah, that
looks good.
Yeah.
When you can't go through like this and it's hard, we do that wire technique and then put the regular bogey and a clamp on it without having to go with the RF. You just take the bovie, clamp the end of the wire, and that's it. Like we do the trans cable.
That's a cheap way of doing it.
Yeah, we always are. Yeah, we're conscious about
that way. Keep going that way. That's it. Now you're right on the tip.
And in these, usually that's the problem. They are thicker. They're more fibrotic.
That's what I suspect because it's like we're going lower
I'm
and
through.
we're right next to
It looks like
the
the stiff end of the V control again.
So that's why he's moving to the V control. So I would take that and put, literally, just take the bovie and put the clamp on it at the end of the wire, and you're done.
Is it, Maurice, is that the soft end of the wire?
Soft end of the wire.
And is it insulated with, is the V18 got an insulation on it? Or?
I use the coronary 014. I don't use the V18.
But I'm not sure, where's the wire now? Is it through? Yes, it
You're
is.
through, yes, you're definitely through.
Okay.
Yeah, I use an 014 wire, and then the back end, usually what's called a confianza, the one that you do CTO with. You cut the very, very floppy tip,
see it on 3D?
and you're let there.
See it on 3D?
Yeah.
It's cheap.
Where's the tip of the wire?
The tip of the wire
is it pulmonary vein, or is it...
Looks like it's...
No, the distal tip in the... is it in pulmonary vein or in the left atrial appendage?
Oh, okay.
And that's a good point to stay away from there.
Yeah. I think it's a
There's
pulmonary vein.
Yeah, it's
but
not
I'm
in the
sure.
appendage. Oh.
No. Let me pull back. Rotate clockwise. This is pulmonary vein. It was at the orifice of the appendage. Right?
It'll be... Which pulmonary vein are you in? The...
I should be in the
upper.
left upper
Yeah,
pulmonary
left upper,
vein.
yeah, we can see you. Yeah. In fact,
So,
if you
okay,
just
I'm
go
through.
around to 45,
That you want to be in the pulmonary vein.
and then roll, take the image that way, flex, and then roll.
The
that's it.
sheath
There
is still hanging on the septum, so I'm through with the dilator, but not with the sheath.
Just the...
That's the ground. And sometimes it's really hard, and you think because you're touching the device at its edge. So that's why I learned to do the RF facilitation and the dilatation.
Yeah, it might be worth using a peripheral balloon with an 035 inch.
And not huge, like it's 7, that's all you need.
Or you can use the Inouye dilator here as well. That would help.
But he's going to do it his way.
He's got it across. There he is. Perfect.
Okay, so now I need some echo contrast.
For those less talented than he is, it's better to do it with that. But it illustrates the exact points. It's thicker, harder.
Ist das hier? Vielleicht eine große Spritze, oder? Was nehme ich da? Fixed range.
Bushra, can you remind us of the measurements of the LAA again?
Yeah, we can just show those
Mit
to you.
Kochsatz verdünnen, oder wie?
From here, it looks like a huge windsock.
So, Horst, would you just go straight with the sheath right off the bat now, or you still have to consider which device you'll be using?
I always use the extra cavitary one.
So can you see the echo image?
Yep.
Okay, so you've got here your 45, your 135, and you can see it's this kind of, multi-lobe, maybe cauliflower type appendage, but it's kind of a hybrid, isn't it, between that windsock and it's clearly got a large anterior or superiorly placed lobe. Now, measurements are, depends where you'd like to go. So at the top here, angle, so you can see the blue line will give you the potential landing zone. So we're cutting through here, the circumflex vessel, or just slightly above it. And these measurements come out as 32 millimeters is the largest, with 24 is the other measurement. And then we just had to think about other places that we could measure. So then the length of the lobe is a good distance, it's 43 millimeters. And then we've done some other measurements by moving the cursor slightly differently depending on where you might want your landing zone. So we've come off the top here and gone to this point where the narrowest part of the appendage is, and that's coming out as 27 by 24. And then we just went slightly above that, and then we've got 29 by 27. So just depends on where we think the landing
I would go down
zone
just
is.
a little bit underneath that trabeculation there. That will be probably about 10 to 12 millimeters in if I'm thinking of an amulet, that
Yeah.
landing zone area.
So let me just go back. So below this one here,
Yeah,
so
just
this
a little
one
bit
is
lower, just a
okay.
little bit lower, just under that trabeculation that's sticking
Okay,
out
so
Peckham Ridge.
I'd have to just go into that 3D data set to have a look at that, which I'm just going to find quickly. Do we think that was a good one? Probably.
There's no questions.
Oh, yeah. So back into the... And now, this might be a problem because you can't see the whole screen, can you, when we go into
That's
the
correct.
software?
We're missing your right screen again.
Okay, so what we'll do is if I just quickly do the measurement, if we go just below that point, so as we go into the appendage, can you see the blue box? If you
we can see just the left edge of that.
Yeah, okay, that's a shame because
just a tad lower, just a tad lower. Keep going, right about there.
So then actually we're now going into the trabeculated area, and can you? I don't know if you can see that the whole thing, it gets much bigger.
Right.
The appendage gets much bigger there. So
that will be if I was going to go for an amulet, that would be the landing zone.
Okay, so let me just measure that. So we are getting measurements of. Okay, we're getting measurements of 37. It's longest. So can you see the whole screen, all four screens now?
Yeah, we can
Oh,
see it.
perfect. So if I go, so this is why I was trying to work out where we thought the best measurement would be. This is the largest orifice in. That's why we've stopped it at this particular frame. And if you look at this shape here, as we move further down, it becomes much broader. Can you see?
Yeah.
But does it really matter how far? Because the whole strategy is not to go deep.
Okay.
So you to
Yes.
focus on the landing zone.
And I'm not too worried about the elliptical nature of here because even the lobe might not cover entirely that little trabeculation. Your disc will, anyways, with the amulet device.
So you'd exclude this
I
area.
won't worry too much about that.
Okay. So you would measure perhaps from here, somewhere there.
Right. I would just measure the
Yeah.
short axis
Okay.
the other way around.
So
too.
we've got 28 by 25. That might be slightly overcalled, maybe slightly less than 25.
And you measured the orifice itself was 30 something. I recall.
Yes, right at the top it was 32 by 34. 24, sorry, 32 by 24.
So you
What do you
could-
think, Kevin? I mean, if you think of amulet, what would you choose?
Yeah, I think there's a big advantage to using LAmbre system here because you're going to have to deliver a 10 French sheath through the septum. That's going to make it easier. And it's a big appendage, so maybe a 3640 or the 34, 38 sort of thing.
But what about the advantage of the technique of going with the ball open and then
Well,
inside?
I think you're going to go with the umbrella open, same.
Same thing?
Yeah.
It doesn't
You can do the
have
same
any-
thing with the LAmbre too, yeah.
So let's do the echo now. So, Busha, where should I inject the contrast? Into the pulmonary vein? Is that okay?
Yeah, I guess it doesn't. I mean, if you can, it'll be fine because it'll be coming straight
Left
in
atrium.
under. Yeah. Left atrium is ideal. Yes, that would be the best place.
So
or
let me
even
then pull back
close
the
to the
shield. So
appendage.
Yeah, left
don't be
atrium.
on the pulmonary
Even-
vein.
Even close to the appendage would be ideal.
Yeah.
Just considering the slow flow.
If you wanted to go as
we need to
stars-
make sure the contrast is agitated quite a lot before we give
Well,
it.
the disadvantage is the sheath is falling down towards the mitral valve. So,
Oh, okay.
actually, let's try it here. Okay?
Yeah.
Ready?
Yep.
Okay.
Can you see it there?
More?
More, yeah, that's it.
It fills the whole thing.
This time we've got to, just keep it open. Keep it open.
Multi-purpose catheter.
So it would have been nice to have more contrast seen, but you can see
But you can
contrast is hanging, dyes hanging up there at the apex there, and you can't see an obvious. Let me just
Surely,
explain
whatever
that.
it is, you don't want to be sticking anything into it, so we might as well leave it alone.
Yeah, I mean, I'm suspicious
right.
it's early thrombus. However, it's small, and like we said, when you look at the clinical indications, it makes sense to do something.
Yep.
Particularly with in horse's hand, who better to do it?
Okay. So, Let me re-engage the pulmonary vein.
So he's gone back up there.
Please direct me when I try to enter the pulmonary vein. I want to avoid the
No, the other way. Or
appendage
that's
here
it,
with
that's
my
it.
catheter.
And there it is. There's the tip.
That should be pulmonary vein, correct? Yes.
Yes. Yeah, you're in there.
Beyond the heart channel, right?
Yeah.
Yep. And so we're going to stay here like this for
Yeah, it's
deployment.
difficult to re-advance the sheath. Oops.
Maybe if you wire your multi-purpose catheter, it'll give you more support.
Yeah. And what I'm doing here now, this is regular contrast. This is regular, this is blood. What I'm aspirating through the sheath.
It's filling pretty good.
It's filling really
It's
well,
filling
though, isn't
distally
it?
pretty good.
So we can use a Watchman, can we?
That's a great idea.
This is
There
Kevin.
you go.
Yeah, okay.
Maurice.
So amplex extra
This is
stiff.
like subatomic particle physics in that
Just roll it.
So which device at the end?
it's like Schrodinger's cat and the box, and that the only way you know is to open the lid of the box, which of course kills the cat. So,
I
and
still
there's a
like-
coexistence of
And I think you've done
this thrombus.
You've done so many injections so far that if it's going to go
in both states, seriously, I mean, this thrombus is just on the cusp of solidity and liquidity.
Yeah. Yeah.
Now it's staying there, you see that?
Yeah,
The
it
contrast
is.
is staying
Nobody
there.
trusted it when I said it was a trabeculation, so that thrombus never was there.
Yes.
Well,
Well, it was
You can't
just...
exclude it's gone somewhere. But
It wasn't a trabeculation.
Yeah.
But even it was, I mean, if the whole point about best risk to benefit is what I think Horst is doing. Try to stay away from it. Try to get a device with the minimal touch technique. It's the best you can do.
That's fine, but I think physically this...
We have the big sheath on
You're concerned.
Well, and I'm just describing the clot or what the process physically, and that's it is both liquid and solid, but interfacing between the two.
So the hope is that it's mostly liquid.
So
The hope is
Horst, there's no
It's
clot
liquid.
there, so shall we give you a few minutes and do a lecture and come back to you because we're a bit behind?
Yeah, that's okay. We will prepare everything and let you know when we are ready.
Have you
to come
decided what device you're going to use?
back. I'm going for the Lifetech device because I had so much difficulties to advance the 8 French sheath.
Okay.
So that's why I
All
go
right.
for
So
it.
why don't we come back to you?
Yeah.
Horst, we're live with you.
So this is the exchange of the 8 French transeptal for the 10 French sheath, which is for
Great presentation.
the Lifetech device. And you can see how we're struggling to get through. So the whole ASD device was moving up. So 10 French only, but still hard to go through. So next step is I exchange this over a wire in the pulmonary vein for the reasons we had discussed. So this is the catheter in the pulmonary vein, the 10 French sheath. This is the angiogram. I pulled back the sheath just to the orifice of the left atrial appendage. It looks different from what we saw in on echo, actually. Multi-lobed, many lobes distally. What's also of interest here, next, so you can see that in one of these trabecula, there's contrast staying for really a long time, which is consistent with what we saw on echo, a very long time. What you see here is not air, this is flush coming from the pressure infusion. There was contrast in before, and then contrast is washed out. Okay, so now I have a what is that, 32, no? 32? 32 Lifetech device.
What were
And
the
just,
measurements, Horst? Very quickly.
we had 24 by 32, correct, Busha, on echo,
Yes,
huh?
that's right,
24,
yeah.
32. And on, actually on angiography, we had a little less. Can you show the photo, please? Can you show the photo?
We can see it.
Okay, so it's 25. It's smaller, so maybe, but it's a kind of a chicken wing, so maybe we can continue with the 32 millimeter device, which was already outside of the package when I saw the angiogram. So now I'm in front of the appendage. I will start opening the device here. like looking at fluoro and echo simultaneously. I want to see, let's zoom in here. I want to see how these arms are folding backwards. Like this. That's a little too much, a little less like this. Huh? Okay. Now I'm advancing the whole thing. Maybe it's too big.
So you're at the left atrial end at the moment on TOE, that's correct, yeah?
Yeah.
That's a little bit better.
Mm-hmm. Now I'm pushing forward,
yeah,
keeping
nice.
it in keeping it in position, and let's record this. Oh, what is that? Cheesecake?
That's an unusual cobra.
Yeah. You pull back.
There's a twist in it.
Yeah. Recapture and redeploy. Unusual, huh? But it's not, I mean, we see this occasionally with the Lifetech device. Let me just do a little juggle test here.
Yeah.
Okay. Good.
Otherwise, you could have had a multi-lobed LAMBRE device.
Yeah, for multi-lobes, yeah.
For multiple lobes.
Okay, so I'm preparing the angiogram here.
Bushra, what do you think, very quickly?
Okay, so you can see it here, 45-degree view, circumflex level there. Disc is partially below that level. It seems to be occluding the orifice nicely. We're just going to explain that. Look at it in the 135 view. So you can see there's the lobe and there's the disc there.
Yeah. So now the thrombus is trapped, if there was a thrombus.
Yeah, and we're just going to go and look at it quickly, so we'll just do 90. That's good, just roll, just in the hold, that's it, back slightly, pull the probe out slightly, that's it, and roll back. So you can see it there, it's in an interesting oblique position, but it is occluding the orifice there with the lobe, with the disc, sorry, and you can see that the lobe, as long as it's stable.
Yeah. Okay, let's just make the fluoro big.
What's the jet that you see there, Bushra, between the disc and the lobe?
So that looks like there is some. So it looks like you've occluded the actual orifice or the landing zone of the appendage, and when the disc lifts up slightly, there's a bit of flow here. Is that what you're talking about?
Beneath that.
So
right
this,
there.
That's an artifact.
That's artifact.
Right?
That's artifact because of the metal on the device.
Yeah. Okay, but it looks good, doesn't it, Horst?
Yeah, absolutely.
Yeah.
So release?
That's it. Yes.
Yeah, everybody says release.
Okay. Oh, yeah. Keep going that way. Keep going.
Including Martin.
That's it. That's it. That's it.
I think he's got a flight to catch. That's why, Okay.
Final angiogram.
Yeah.
Yeah, looks good.
Yeah.
Okay.
Excellent.
Thank you very much.
Thank you. That was very good. Big hand for the whole team. Horst, we've got around at least 2, possibly 3 talks. Have you got another case to do?
We have another case, but I think at what time is the program over? I'm not sure. Is it how many?
6 o'clock.
6 o'clock.
20 more minutes.
Okay, and you have more talks than
we've got.
Then we have one more case, but then we have to stop transmission here.
Yeah.
So thanks to all of you attending this course. Thanks to the faculty, the industry, and everything else who is in the room or not in the room at this time.
There's quite a big audience still.
Oh, still,
which is surprising.
Surprising. Thank you very much, Jacques. We will talk later.
Horst, congratulations on an excellent day of case demonstrations.
Thank you very much.
All superb.
Thank you.
Okay, well done.